Hi, good morning, everyone.
Good morning.
Good morning.
Very good morning.
Good morning.
Good
We're
morning.
still not seeing the course key, just so you know.
Okay, thank you. Yeah, I'm trying to figure out. I don't know why. It might be, maybe I'm not doing something correctly. Because I think I did share with you, right, that my computer crashed last week.
You did.
Yeah, it was a big mess. Everything wiped out. I'm still not able to recover any of the data. Everything was on it. And very interestingly, everything which was backed up on the cloud, that's gone as well. I don't know why. All my work was gone. So a whole lot to do. And I purchased actually Apple. And I never used an Apple desktop. So this is a little different for me. So there is a chance that maybe I'm not doing something correct. Maybe I need your tech support in that. You guys are pro in that. Let me see. Okay, do you see anything now?
When you share your screen, you might have to click there, that. Don't touch anything. There you go.
Can you see now?
Yes.
All right. Okay. And do you see the full screen or you see that the presenter view?
It looks like it's your first slide, the course key.
You see the course key, the full screen, right? Only that.
Yes.
Okay, perfect. Please let me know if any of you experiencing any issues. Scanning the QR code. Looks like majority are in. Some we are still missing. Nathan, Alexis, Carly, Simon, and Nico. Yeah, the 4 or 5 still missing. Any question, guys, while we're waiting for rest of the students to join?
I wasn't able to, I don't see course key, so I can scan in.
Oh, it doesn't show anymore?
It's not showing on my screen.
How about
you might have to make Professor like the main person on your screen.
Oh, okay. They put y'all in chairs. Nope.
Are you clicking on view, Carlise?
Yes, I am.
And doing gallery or speaker, one of the two? And you don't see anything?
Nothing. Nope.
I'll check you in, Carly. Okay.
Thank you.
No worries.
Professor, I do have a question about the test on Friday. Are we gonna have med calculations again on that? Will that be like recurrent throughout?
Yeah, it's in all your weekly as well as final exam. You do have calculations. It's not a set number, but somewhere from 6, 7 to 8, 10, but here and there, some couple less, couple more, but all of them has some.
Okay, are you able to share which med calculations will be on there or just all of them are fair game?
Yeah, they're generalized, spread out. It's not that any certain type in any particular week. They're all just spread out. Similarly, how you saw in the previous week, same way.
Okay.
Yes, who else has question? I see some hands up. Yeah, go ahead, please.
Can you sign me in? I don't see a QR code on the when I logged in. There was no code.
Okay, all right. Let me look. Okay. Okay, Alexis, you are in, ma'am. Okay, who else? Daniel, you have a question as well, or?
Yeah, I was just wondering if there's a way, if you can go over like examples of different calculations, different methods, or
I'm sorry, I don't know if it's on my end or is it everybody kind of hear that distorted voice? But I didn't understand much of what you said.
Sorry, here, I'll type it in the chat.
Okay. Yes, Nathan.
Can you also sign me in, please? I don't see a QR code.
Yes, sir, absolutely.
Thank you.
You're very welcome. Okay. Who else? Who else?
Could you sign me in as well?
Let me see. Nico, are you, you're checked in. Okay, let me see here. Okay, here, there. Okay, looks like everybody is checked in the course key. Okay, so everybody's good. All right, let me read the message. Okay, yeah, I read your message. As I mentioned last week, why not let me look into what day before your next exam. Let's just schedule a dedicated session for calculations. And then I can go over the way I do. You don't have to follow that way, whatever the way works for you. But I always say, follow only one method. Do not try to do multiple ways because that's when we mess up. Always adopt one way. Just make that refined and follow it every time. Remember, one thing I'll tell you, it's not about that you don't know how to calculate. It's nothing like that. It's about consistently doing it the same way every time. This is my first step. This is my second, third, fourth. No matter how hard or easy the problem is, follow the same step. You will get the answer correctly. It's all about putting things in order and just follow that order every time. You guys can do any calculations. That's not a problem. But it just consistently doing in the same way, that is what you need to do. Because when you see an easy one, we jump. That's human mind, right? Okay, I got it. But then that's a habit. And then when you see a hard one, you're gonna jump, you are going to miss something, or this third will be at second spot, second will be at third, and the numbers change. Okay. Anybody have question? I see one hand raised. Is it something different, or was it about, okay, that's gone now. Okay, all right. Anybody else, guys, before we start the lecture?
Thank you for the 5% for the quiz.
You're welcome. I did that analysis and did find a few things, and seemed to me that maybe that was not fully clear in your mind. So that happens probably when you don't have 100% clarity about a topic, or you miss tiny things here and there. So it's okay. But in general, you guys did well. I see, quite well you guys did. But there is always room to improve. So we'll keep working. Okay. Why am I not able to do this? Okay, and okay. Here. Can you see my screen though, or no?
No, you might have to exit out and then do the same thing that you did with the course key.
You see it now?
Yes. Yeah, we can see your screen.
We can see your screen. You just have to hit enter or next so you can go to your main slideshow.
The next slide. But you can see the course key, correct?
Yes.
Correct.
How about now? Do you see the full screen?
Yes.
Perfect. All right. I'm learning from you guys. Thank you for your valuable guidance, guys. I told you I'm new in this. Okay. Here. I'm used to that Windows, and I'm looking everything to open, close on the right hand, and then this Mac opens up on the left. Okay. All right, guys, let's start the first one. You can still see, right? Nothing disappeared. All good?
We're good.
All right. So first chapter of the day, antihypertensives, antihypertensive. So first of all, we're going to talk about hypertension. What is hypertension? And then we'll look into the solution, okay? And all relevant information, the drugs, their indication, adverse effect, interactions, all important aspects of your nursing care plan. That's what we're going to discuss in this chapter. So first of all, I'm going to play it real quick. Let's see how long that is. There are more videos, but I'm not going to play all. So here and there, we'll play some short ones, and we'll move forward.
Hey guys, Nurse Mike here, and welcome to SimpleNursing.com. Before we get today's lecture started, please remember to access your free quiz and preview our cool, nifty new study guides, not here on YouTube. Click the link right up here at any time during this video. All right, guys, let's begin. Dawn is a 55-year-old truck driver who presents to urgent care with a throbbing headache. 8 out of 10 pain, and intermittent episodes of blurred vision that seems to be getting worse for nearly a week now. Upon assessment, the nurse finds he smokes 1 pack per day and frequently eats fast food on his daily routes. His history includes type 2 diabetes times 20 years, stage 2 hypertension, hyperlipidemia, and a recent diagnosis of COPD. Oh snap! What is Don's main priority right now? And what must you, the nurse, prioritize in his plan of care? Today we're wrapping up hypertension, which is high blood pressure. So just think high tension on the arteries and vital organs. Now, normal BP is 120/80. Systolic is on top and diastolic is on the bottom. So our memory trick is San Diego. Systolic is the squeeze and expansion of blood vessels under pressure. And diastolic is that decompressing, that relaxation of the vessels. Now in hypertension, we have high tension on the heart and blood vessels. So remember, by saying anything over 140, the heart says, oh lordy. Now as far as your numbers, the elevated BP starts at 120 to 129/80. Stage 1 hypertension is 130 to 139, and diastolic is 80 to 89. Now we start taking major note when it gets to stage 2, this 140/90. Remember, 140, the heart says, oh lordy. Now hypertension crisis is anything over 180 systolic and 120 diastolic or more. Now this is super dangerous because it can cause brain damage and even a heart attack. Now as far as the signs and symptoms of hypertension, hypertension usually doesn't cause any signs or symptoms. Since it creeps up over time, we call this the silent killer. Now if there are signs and symptoms, our 3 most common signs and symptoms on Select All That Apply questions, and even on the NCLEX and nursing exams, use the acronym ABC. A stands for achy head or headache, and this can lead to a CVA stroke. B stands for blurred vision, also called retinopathy. And C stands for chest pain, which can indicate a heart attack. Now again, severe hypertension is called our hypertension crisis. It starts with anything over 180 systolic and 120 diastolic. Now it's an emergency crisis since it can kill the patient and destroy the 4 main vital organs: the brain, the heart, the lungs, and the renals, basically your kidneys. So we give IV drugs immediately. So remember B, C, D, and E. B for beta blockers, that puts the brakes on the heart, slowing it down. Our C is for calcium channel blockers. Remember, calcium calms the heart and controls the blood pressure. D for dilators, like vasodilators. So remember, D for decreases the blood pressure, because remember, nitro acts like a pillow for the heart. Rest and relaxation. And lastly, E is for ER to ICU, since it's a crisis situation. Now, thanks for watching. For our full video,
Okay.
hey guys, Nurse Mike.
Hope you were able to kind of see the basics, how we define hypertension and what the problem is. So simply remember, too much pressure, too much tension, too much stress on the heart. And that's when the heart aches. So 120/80 is that's what normal. Then it jumps into different stages, such as pre-hypertension, then stage 1, and then stage 2. So this is another way to see it. For example, normal 120/80, elevated when there's a jump of 9 points, even though it's in 1, only systolic. Still, it is elevated. Now, another jump of 9 points on either one or both, that is your hypertension stage 1, and then anything beyond 140, and on the other side diastolic 90 or above, that is your stage 2. But hypertensive crisis, which is a red flag, patient should be in the ER. 180 or 120, anything above that, that is a red flag. Okay. Now, based on patients' underlying conditions, their age, you have to look up differently. Okay. The patients who are younger, but their blood pressure is higher, they probably need a little bit more aggressive approach. As far as older patients, they look at it differently. When the body parts, they are in decline phase, they're not fully functional. So you will see numbers going left and right in that age, a little bit, but not completely different, but slightly. And based on that age, that might be their normal, such as 150 over 90, anything, that's where you start for anybody 60 years or over. But 140 over 90, that's what you should start when somebody's younger than that. So when your patient is younger at early or less severe stage, that's when you start the medication. And it's a little bit more lenient numbers when they're older. Okay. Now, as far as the types, sorry, I forgot to ask. Can you still see the full screen?
Yes.
Okay. Because as I said, I am a newbie here about a product, so I can mess up. Okay, so please let me know. So essential or primary, as well as called idiopathic, that is the highest percentage number of patients suffering from hypertension when you don't know the cause. And secondary when you know the cause, and that's a very small percentage of patients. Okay. Once again, primary and secondary. Primary, also called essential or idiopathic, we don't know the reason. 90% of patient falls under this category, and only 10% under secondary hypertension when you know the cause. Maybe it's because of the kidney disease, or maybe some other disorder, or patient is pregnant, the patient is on certain type of medication which are causing the blood pressure to go high. Now, what are the reasons behind hypertension? It could be many, 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 any and many. One of the biggest ones are what we eat, what we do, what we put in body. That makes a huge difference, right? So it's important, patient watch. Keep an eye on what they eat, read the labels. Too much stress. Salt is a big contributor, age, yeah, normal, heredity, as well as obesity, too much weight, sedentary lifestyle. Those are big contributors. And your patient may experience different symptoms. It could be just headache, and it's called silent killer, as I mentioned in the video as well, because patient may not experience any major sign and symptoms. So it could be just slight dizziness or mild headaches until it becomes severe. So what you do here is, first thing is lifestyle modifications. What that means is change their activity level as well as what they eat. So dietary changes they call as DASH diet, dietary approaches to stop hypertension. So in simple means, this diet includes more fruits, vegetable, low-fat dairy product, and watching the sodium intake very closely. They should restrict the sodium intake, I would say below 1500 to 2000 milligram a day, not more than that. Okay. Then on the other hand, whatever they have, then how to do things differently that they can achieve the goals, such as weight management. Weight management, they are overweight. Educate them about the risk associated and the benefits of maintaining a healthy weight and what they can do. So BMI below 25. Tell them to exercise regularly. These are the habits they need to develop, because none of the medication is going to manage their condition effectively if they're not going to make changes in what they eat and what they do. So regular physical activity. Then ask them about what else, such as alcohol, smoking, big things. If they do, well, encourage them to stop smoking and then assess them. Are they ready? If they're ready, give them information regarding the smoking cessation programs. If they're not, assess it again during the next visit. Educate them. And if they drink, ask them how much and also encourage them about reducing, if not stopping, at least reducing the alcohol intake. It would be better if they can stop. Now, what if they did that, or to some extent, and the desired goals are not met? Okay, blood pressure is still high. Well, you may need to introduce therapeutic agents, right? The pharmacology agents, your drugs. Now, there are many drugs available, such as your ACE, ARB, calcium channel blockers, diuretic, vasodilator. All these are your antihypertensive medication. Well, then which one do you choose? What are the first line, second line? We need to know that. Usually, first line, if it's not too bad, you may see a thiazide type diuretic, like, they end with thiazide, chlorothiazide, hydrochlorothiazide. Those are your thiazide diuretics. What they do is they're also actually called the water pills. I'm sure you probably heard about the water pills, right? So what they do, they increase the outflow, right? The patients pee a lot with that. So those should not be given later during the day, because then they will be waking up at night to go to the bathroom, because it helps excreting more fluid. So now it's less volume to pump. And who's the pump here? Heart, right? Heart is a pump. So when you have more volume, it has to work hard, correct? You have more work, you get tired, obviously. Then how you can be at ease when you have less work? And heart's work is to pump the volume. And when you reduce the volume by excreting it out, so there's less to work on, and that keeps your heart at ease. Does it make sense? Yes. Okay.
Yes.
Now, other choices, they're usually ACE or ARB. Remember this thing, ACE, and there's a big OR. They're never and. They're never taken together. Severe hypertension, okay? Severe interaction. It's either or, ACE or ARB. Know that part, okay? They test this on NCLEX all the time, because that's a big thing. ACE or ARB, always, never ACE and ARB. Now, what are ACE? They're angiotensin converting enzyme inhibitors. ARBs are angiotensin receptor blockers. Okay, then they're calcium channel blockers, they're beta blockers, they're combination therapies. And let's look into some names here. For example, somebody just newly diagnosed, okay? Now, based on their age, if they're younger, they're older, you may go with a different approach. For example, A means ACE, right? You chose ACE or ARB, ACE or ARB, but somebody older, and another important part here, if they are African American, because of the genetic structure, they do not respond well to ACE or ARB. For them, you gotta go with C or D, means calcium channel blocker or thiazide type diuretic. They respond better to that. They always ask and then collects that question as well. Okay, everybody clear? Any
Yes.
question? All good?
Yes.
Okay. Now, if the patient feels better, good, continue. If they don't, well, then we need to step up the therapy. So from one, maybe another one. Like here, if you chose ACE or ARB, suppose ACE, then maybe you can add calcium channel blocker. Here, if you had whatever C or D, or here, whatever, you can add another agent. But just keep an eye that you're not giving ACE and ARB. Okay? Others can be given. Then still not there, well, and another one. Always it's better to add another agent to keep all drugs strength or dosage low rather than going high on a single agent. We don't want to put them in risk of high adverse effects. Okay. All right. So that they're drugs. First category, like all these, they fall under adrenergic drugs. Okay. Subcategories such as centrally acting, your clonidine, methyl-dopa. These are used in when somebody's blood pressure is really high, like in emergencies. Okay, adrenergic drugs, they affect the adrenergic receptor in the body to manage the hypertension. So modulating the sympathetic nervous system either by blocking its actions like as an antagonist or mimic its effect as an agonist to control the blood pressure. So subcategories here, the central acting, there's this alpha-1 blockers, means they act only on alpha-1 receptors. Remember the different types, alpha-1, alpha-2, beta-1, beta-2. So alpha-1, these drugs ends with zosyn, then they're beta blockers. They end in LOL. There are dual acting, means they act on more than one receptor, such as alpha-1 and beta receptors as well, such as your labetalol and carvedilol. Okay. They have antihypertensive effect as well as reduce the heart rate and then causing vasodilation. Okay, now indication, what they're used for. Well, we're talking about hypertension, so most definitely they're used for hypertension. There are other conditions where they can be used, for example, glaucoma, such as timolol. What is glaucoma? Anybody knows what is glaucoma?
Is it high blood pressure in the eye?
Yeah, good job. Simple words. It's hypertension of eye, too much pressure in the eye, which is called intraocular pressure, the pressure in the eye, right? And these drugs such as beta blockers, very commonly used timolol, it increases the output means is increase the outflow of the aqueous humor, also reduce the production of aqueous humor, overall reducing the intraocular pressure. Then in BPH, your alpha blockers, they are most commonly used. Benign prostatic hyperplasia. and they end with Zosyn. One of the biggest concern with these drugs, hypotension. Remember, what is the problem? Hypertension, correct? What is the drug gonna do? Reduce the tension, correct? Hypertension, it's gonna bring the blood pressure down. And the most common problem that can happen is a little low than expected. So always it's opposite to the problem. So problem is high. When you're trying to fix, the risk is down.
So question,
hypotension.
that would be considered a side effect and not an adverse effect?
Okay. Now, what is the difference between them? Can you tell me what is the difference?
Side effects may be expected reactions to the medication versus adverse effects is life-threatening.
Correct. So one is just an extension of what is what you're trying to do, right? The other one is more unexpected, correct? So this is expected.
Okay.
Makes sense? So one of the biggest concerns with these drugs is hypotension, but certain classes, such as your Zosins, alpha blockers, has a higher chance of causing that. Okay? Now, at the bottom, you see asthma and beta blockers highlighted. Why? Especially, keep it generalized though, but especially non-specific beta blockers means they can affect more than one. Remember, beta 1, beta 2. Beta 1 works on heart, beta 2 works on 2 lungs, right? 1 heart, 2 lungs. Beta 1 on heart, beta 2 on lungs. While you're trying to use the drug to produce its effect on the heart, but if they're not specific, then they can act on lungs as well. And they act completely opposite way. They cause constriction in the lungs. Okay, so if somebody has asthma, COPD, what is their issue? Breathing, right? And if we constrict the airway more, the problem is going to become more severe. That's why we will look for those patients, and it is contraindicated then any patients with asthma, COPD, severe condition, they should not be on the beta blockers. We're on the same page? Everybody's clear about the concept? Please let me know if you're not clear. Okay. Adverse effects. As I said earlier, always think opposite from the problem you are trying to fix. You're trying to fix the high blood pressure. The most common issue they may experience is low blood pressure, hypertension. It's called orthostatic hypotension. When you're trying to stand up from sitting position, that's when the highest risk. All of a sudden, now the heart is not ready to pump, okay, that strongly, and it takes a little while for her to catch up. That's why I always recommend them change position slowly so that they don't feel dizzy, and sit before you stand to prevent this orthostatic hypotension. Okay, another addition, especially your alpha blockers. I mean, all can, but alpha blockers have a higher chance. It's called first dose syncope. First dose syncope means the first dose given to them, they might be at a high risk of blood pressure dropping down more than expected, because we don't know. Every patient's body is different. How they're going to respond to the drug, it's different, and we don't know about that patient, how they are going to respond. So you have to be very careful for the first dose and educate them that take the first dose when you're lying down, means at night when they're going to bed to reduce that risk of fall. Okay, that is very important. Anybody going on the medication, especially as I said, your alpha blockers, how do you identify alpha blockers? They end with zosyn, doxazosine, terazosin, okay? Those high risk of first dose syncope, the solution is give it in the bedtime. Everybody's good? You all clear on that point? Okay. Remember, remember, remember. Let me say it again. Don't try to remember everything. Don't ever try to memorize every single drug, every single thing about the drugs, because it's not going to happen. Okay? Then next question is, what do I need to know? Ask yourself, what is important about this drug? And how do we figure this out? What is important about this drug? Well, what is the use of this medication and how does it work? Because this drug works to bring the blood pressure down when certainly we don't know. Well, we see things going up and down more or less than expected. Well, that is the biggest risk, completely opposite, hypotension. And when somebody experiences hypotension, what can happen? They can fall, right? That's safety risk. Well, that is important. That's what we need to know about this drug. Then what else important? Well, everything around that risk. Educating the patient to prevent, how give them at nighttime, tell them sit before stand, because we are focusing on whatever the biggest risk associated. Is all right? Do we need to know that for acetaminophen, Tylenol? No, right? Why should we focus on that? For Tylenol, we need to tell the patient, watch your liver, correct? Now, is the same thing applies for ibuprofen? No. Well, then what's important? Mainly GI issues, GI bleed and stuff. That's what we need to look into. Cardiac patient, that's what we need to focus in. When you read a drug, ask yourself, what is important in this? And that's what you should highlight, put in your study guide. That's what you should focus on more. Give it general reading to everything, but then focus more on what is important. NCLEX do not expect you to know everything, because even the nurses working from 15, 20 years, even they don't know everything. But they want to make sure you can keep your patients safe. For example, we're talking about these alpha blockers and you don't know what the risk is, hypotension, and what are potential risk associated with that, the falls and all that, and how to prevent that. Well, that's what they will be concerned about. Correct? Learn what they want you to know and know that. Don't go random learning journey. Let me learn everything and they can ask whatever they want. It doesn't go that way. Okay. All right. Now, interaction. Remember, they bring your blood pressure, your patient's blood pressure down, correct? So interactions would be what? Any drugs or substances which will bring your patient's blood pressure down. Now, two things which brings their blood pressure down: high risk of more blood pressure down, high risk of falls, correct? So common sense, alcohol, opioids, right? Benzodiazepine, sleeping pills given together, that will suppress their CNS. CNS suppressed, while their blood pressure is going to go down. That is high risk. That's what we should look for. Those are interactions, correct? Interaction is what? Well, why we're looking for interaction? So that the patient is not at increased risk of injury, correct? Now, these are your centrally acting, and as I said earlier, these are more, for acute conditions when blood pressure is going high. So they stimulate alpha-2 receptor in the CNS. What does it do? It blocks the release of epi and norepi. Well, what do epi and norepi do? What has to do with hypertension? Epi and norepi, they are vasoconstrictors. Okay, remember two things in hypertension: vasoconstriction and vasodilation. When somebody has high blood pressure, means they're experiencing vasoconstriction. When the vessels constrict, they push the blood, strongly increases the pressure. Okay, these drugs block the bad guys, epi, norepi, who causes vasoconstriction, resulting in vasodilation, which eventually decrease the blood pressure. Make sense? Are you able to see the sequence? Can you visualize it? Epi, norepi causes vasoconstriction. That's what's happening in your patients with hypertension. So we need to fix the problem. How? Whoever is causing, and who's causing? Epi and norepi. We block that. Once there is no or less epi norepi, means less vasoconstriction, resulting in more dilation. More dilation, now it's less stress, less pressure, dropping the blood pressure. Okay? So your clonidine, methyl dopa, they're most commonly used. One more important thing, make sure you know that. Because you may come across patients who are pregnant with hypertension. Pregnant hypertension, what is the drug of choice? Because we need to make sure that it's safe not only for the mother as well as for the baby, right? So methyl dopa is the drug of choice. So please remember that. Methyl dopa is the drug of choice in pregnancy. Okay, let's move on to another important one, which we talked briefly. Alpha blockers. And they're alpha-1 blockers, so block alpha-1 receptors. First thing is knowing which drug belongs to what class. Write down at the top, alpha blockers, then just leave a little hint, write down Zosyn, Z-O-S-I-N, so that you can identify drugs ending with Zosyn. These are your alpha blockers. Then write a hint. Big risk, okay? Maybe in red color, right? Highlight with red color. Hypotension, or just put an arrow downwards, and BP means low blood pressure is the highest risk associated with that. When you develop your study guide, be specific and very concise, short form. That's how I used to develop. Like I never wrote down the whole sentence, like, a decreased blood pressure or whether this, whatever. I'll put an arrow down, means going down. What? BP. There you go. Done deal. Okay. So make it concise, just hints for you. Don't make your study guides too bulky. That is similar to trying to know the whole town, which we don't need to. We only need to know our family, just who supports each other. And that's how you should develop your study guide, concise. Making sure all important family members are included, but you're not trying to invite the whole town in your party. Okay, I hope it makes some sense, because that's very common. And we're trying to learn everything. And please understand it. You don't need to know everything. We all have to focus on what is important for us to know. And I'm telling you what is important to know. Okay, so when you create your study guide, put things in a way that you're not leaving your family out, but at the same time, You're not bringing unwanted guests on that list because it'll make it bulky, and then you'll roam around in the town and looking for the address, finding yourself lost and falling behind on things. We don't want to be in that situation. And creating your study guide is such an excellent tool. I cannot stress enough on this. And let me tell you something honestly by myself, okay? When I went to pharmacy school, the first year, I never developed my study guide. And I thought like I'm saving time. Oh, everybody's developing study guide and I'm studying at that time. I'm grasping the information during that time. Well, guess what? When I realized, I just told myself, oh my goodness, how smart you were, right? So that's one of such a handful tool that which can help you to revise the most important thing in minutes. I can do that for what? Like I spent hours and hours to go over that bulky material. Rather than that, I would spend few hours to develop that concise form, and I can go over that 10 times and we'll still save time. What is the biggest challenge here? Too much and too less. Am I correct? Right? That's the biggest challenge. And that's where this comes handy. So please do not make that mistake what I did in my first year, okay? Not creating your study guide. All right, now, once again, alpha blockers, they block alpha-1 receptor. They are in vascular smooth muscles causing vasodilation. When there's dilation, blood pressure drops. Okay, we know the mechanism of action. Once again, how we identify, ending with Zosyn. Excuse me. What is the biggest concern? Hypotension. What can we do? Give it at the bedtime, the first dose syncope to prevent that, because we don't know how the patient is gonna respond to that dose. They may feel dizzy. Tell them, take the first dose when you're laying down. Okay, is everybody clear with me on this? What is important about alpha blockers?
Yes.
All good? Okay. Next, here comes beta blockers. As the name say, beta blockers. What do they block? Beta receptors. Okay, beta receptors. Now, beta receptors are two types, beta 1, beta 2, correct? Beta 1, where they belong?
Heart.
Heart. And beta 2?
Lungs.
Lungs. So which one do we need here?
Heart.
Heart.
Beta 1, correct? Beta 1. But if the drug is non-specific, even though you don't need them to work hard, but they may feel obliged like, oh, you know what? I have a little time. Let me go to lungs and just check out if they need any help. Well, we don't need them because they're going to cause an opposite effect, causing problem, means constriction of airway, which is a problem for asthma COPD patients. So our concern with the beta blockers, patients with asthma COPD, correct? So that is very important to know. Now, how do we identify which drug is beta blockers? Well, write down beta blockers. Now, point and arrow, write down LOL. The drugs I find which ends in LOL, they're beta blockers. What do I need to watch for? Well, patients with asthma COPD. Correct? Another thing here is beta blockers can also increase, blood sugar. For diabetes patients, we need to monitor their blood glucose. But very important thing is diabetic patient, they not only have high blood glucose, when they take antihypertensive, well, there is a risk of not antihypertensive, I'm sorry. When they take diabetes drugs, those drugs, especially like high risk drugs such as insulin, the blood glucose can drop as well. Risk of hypoglycemia, correct? Now, how do you know somebody's experiencing hypoglycemia? Well, one is you check their blood glucose, but how would you even know that I should check it? Based on certain signs and symptoms, right? That little shaky, feeling cold,
Cold and
sweaty. Go ahead.
I was gonna say cold and clammy, give me candy.
Yeah. So why we are talking about the beta blockers here? The beta blockers can mask all those symptoms which patient, when they're experiencing hypoglycemia, what they experience, all these symptoms we talked about, the beta blockers may mask them and the patient may not experience, and a nurse or any healthcare provider may not notice that hypoglycemic episode, and the patient might be high risk. So what can we do? Monitor their blood glucose more frequently. Make sense? We know that's a risk. We take initiative steps to avoid that, prevent that from happening. So beta blockers, once again, selective, non-selective, okay? Selective, non-selective. And what do we use for? Well, hypertension. These are also used for angina, migraines, headaches, stage fright, usually one dose given when somebody is frightened, and having a hard time facing the audience and present in front of them, just a single dose. Now, once again, your beta 1, beta 2, okay? Remember this thing. A, C, B, D. A means alpha, they causes constriction. B means beta, beta causes dilation. A, C, B, D. Now, beta 1 belongs to heart, beta 2 belongs to lungs, right? How do you know selective and non-selective? Remember this little tool here. The drugs, their name starts from A through N. Okay. Examples there, atenolol, metoprolol, A through N. They are selective. All others, mostly you may find maybe one or two exceptions here and there, but majority, anything other than falling between A through N, from O through Z, they are non-selective. So those are what more risk of for asthma COPD patients, because they will go wander on the lung side as well. Okay, because they're not specific only for one receptor. Okay, now they're dual action. They work on alpha as well as on beta receptors. And these are labetalol IV, given usually for hypertensive crisis, somebody's experiencing myocardial infarction, heart attack, usually given as an IV to drop the blood pressure in step-down approach, like 20 in an hour, then another 20 hours, so like that. Okay, so labetalol, carvedilol, these are the ones under that category. So they cause, once again, vasodilation and reduce the patient's heart rate. Okay. When they block the beta receptors, they reduce the heart rate. When they block the alpha receptors, they cause vasodilation, once again, resulting in low blood pressure and using hypertensive emergencies. Okay, now ACE inhibitor. Remember, these are first lines, okay? First line is ACE or ARB, angiotensin converting enzyme inhibitor. How do you know these are ACE? Now write down ACE inhibitors. Point and arrow and write down these drugs ends with pril, P-R-I-L. Look here, P-R-I-L, pril, pril, pril. So that is how you remember which drug belongs to what class, like how previously LOL, those are beta blockers. So pril are your ACE, okay? Now, as far as ACE, how does it work in reducing the blood pressure? Well, ACE is angiotensin converting enzyme. What it has to do? Well, everything. ACE is an enzyme which helps converting angiotensin 1 to angiotensin 2, and angiotensin 2 is a highly potent vasoconstrictor. And what happens when there's vasoconstriction? Blood pressure goes high, correct? So you're blocking the conversion of angiotensin 1 into 2, which is a vasoconstrictor. So you're not letting that conversion happen, which eventually would cause vasoconstriction and increasing patient's blood pressure. So you're blocking that. Okay? Because, like here once again, you're blocking the ACE because ACE causes conversion of angiotensin 1 to 2, and 2 causes vasoconstriction, which increase the blood pressure. And you blocking that, you are pretty much blocking everything which was going to happen. Okay, now important, if somebody asks you which antihypertensive are first line patients with heart failure, you know, they have hypertension and heart failure, which one to choose? Well, as I said earlier, it could be ACE or ARB. And in heart failure patient, another one you will see commonly are the beta blockers. So ACE or ARB or beta blockers, these drugs you will see prescribed to these patients. Okay. Okay, now ACE inhibitors, they have some additional protective effects on the kidneys as well. And that is important to know. Why? Because your diabetic patient over time, what they can experience? Damage to the kidneys. Over time, slowly. Over time, silently, their kidneys get damaged. In order to keep their kidneys safe, ACE are a good choice. So for patients with diabetes, to keep their kidneys safe, ACE inhibitors can be given. Okay. Everybody understood that point? That is very important. Now, these drugs, what are the common or severe adverse effects associated with that? And one of the most important what they test you on is non-productive or dry cough with ACE inhibitors. That's something unique with ACE inhibitors. The patient is coughing, it's dry cough. They don't know what's going on. It's just coughing like crazy. And some of them, they can't even sleep well at night, and they may have to discontinue the medication if you get that severe. But is it like happens to everybody? No. If that happens to everybody, probably would have stopped production of this drug, but it does happen. So you need to know if the patient is complaining about dry, non-productive cough, look at what they're taking. It could be because of ACE inhibitors. Okay, most of the times, once you stop it within a week or two, it stops. But in some patient, it may not for maybe a month or two. Other thing is, hyperkalemia, too much potassium, and angioedema in some cases. Okay. Not everything you have to memorize, but these few things what I told you. Dry non-productive cough, high potassium, hyperkalemia, angioedema, and certainly because this medication brings patient blood pressure down, so hypertension for all the drugs will be some sort of risk. Now, NSAID, lithium, potassium sparing diuretic, how does that make difference? For example, if it's taken with NSAID, it can reduce its efficacy and the blood pressure may not be controlled, managed well. Now, potassium supplement, because this drug can increase patient's potassium level, and if they are consuming more potassium, it will increase patient potassium even more, and very specific about when they're using potassium sparing diuretics such as spironolactone. So with that drug, it lets potassium sit in the body, water goes out, but the potassium increase in the body. And if they are taken together, potassium might be severely high. Okay. Now, this drug, captopril, why I put it here is because I want you to know something here. Your patient might be completely, not healthy. I would say that their organs are healthy, right? Their liver, kidneys, all are fine, working fine. But you may come across patients who say, oh, you know what? My liver is not 100%, like, impaired liver functions, liver cirrhosis and all that. How does that impact? Well, liver is the major organ who metabolize drugs, right? If their liver is not healthy, they cannot metabolize well. What can we do? We can give some drug which does not require liver's help for metabolism, right? Now, there are drugs called pro-drugs. What that means is they are an inactive form outside. When they're taken, then body converts it, usually liver converts into the active form. But as we talk about that some patients, if their liver is not fully functional, you cannot give them a pro-drug. The drug has to be in its active form, and captopril and lisinopril are the drugs which are in active form, which can be given direct, and even if their liver is not fully functional, they will still be effective. Okay, so it will be safer to give in those patients. Right, everybody's okay?
Yes.
Any questions so far, guys? No? Okay. Let's move on then. Excuse me. Okay, I just put these drugs on there so that you know nothing additional you need to know about this drug than the whole class. Now here's another important one as we talk ACE or ARB. So this is also first line. It's an angiotensin receptor blocker. ACE was angiotensin converting enzyme inhibitor. So ACE inhibitor, they block the enzyme who helps the conversion of angiotensin 1 to angiotensin 2. But these drugs, they do things differently. They don't block that conversion. They don't let the angiotensin 2, which is a vasoconstrictor, bind to the receptor. And the effect is only when they bind to the receptor. They block that. How do we know that these are ARBs? Well, they all end with sartan. So once again, write ARB to identify sartan. They end with sartan. How do they work? They block the binding of angiotensin 2 to the receptors. Okay. Now, What is the other important thing about it? Very important thing about these drugs. They are contraindicated in pregnancy or lactating mothers. Pregnancy, lactation, it is a big no, 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 and a no, another no, okay? So that's important. How this looks like. See the ACE angiotensin 1 to angiotensin 2. This is where the ACE inhibitors block this conversion because this guy is a vasoconstrictor and vasoconstriction causes high blood pressure. But the ARBs, they don't do anything here. What they do is they don't let this gentleman bind to the receptor. Okay, resulting in vasodilation and a low blood pressure. And these drugs, ARBs, they don't cause that dry cough and that kind of stuff. What else? What else? What else important? Okay, here's an example like losartan. Okay, losartan. Now, once again, and this is not only for losartan, this is for the whole class. For breastfeeding, pregnancy, it is a no contraindication. That is a very important point to remember about these drugs. Okay. I'm not worried much about anything else with these. Okay. Here comes another one. Calcium channel blocker, CCB. How do we identify them? They end with pine. CCB ends with pine. Okay. As the name say, they block calcium channels, calcium channel blockers. They block the entry of calcium into cardiac and vascular smooth muscle cells, so which leads to vasodilation and causing low blood pressure. There are two different classes. There's a dihydropyridine and non-dihydropyridine based on their structure. In non-dihydropyridine, there are two, verapamil and diltiazem, and those are the only ones which do not end with pine. Everything else, they fall under dihydropyridine and they end with pine. Okay. There's nothing different here. This is what looks like. Dihydropyridine, non-dihydropyridine. Non-dihydropyridine, usually you will see this verapamil, diltiazem, which do not end with pine. All other, they fall under dihydropyridine. They're calcium channel blockers. Amlodipine, nifedipine, fluoxetine, they're all your calcium channel blocker. Okay. This is what it's shown here as well. Nothing different here. Okay, another important, these are a little milder, usually kind of one of the starter ones. Your water pills, diuretics. Okay, most common, or thiazide type diuretic. Now, what is important about this drug? Remember what they do, how they work. Well, they increase the outflow, correct? Increase the volume output, urine. So the patients pee a lot. So what is important to monitor here? Their fluid volume status. They're going to lose fluid, as well as, remember, water doesn't go alone. It takes electrolytes as well. So fluid volume status, what that means is intake, what they're putting in, output, what is going out, and their daily weight. These are critical to monitor in these patients. Correct? Because if they are gaining weight, what does it mean? It means pump is not pumping out. That's the problem with the pump. And what is the pump? The heart. These are indicators. If you see edema in patient, what that means? Fluid staying in the body. Why? Because it's not going out. then who is supposed to send it out? The pump, heart. That means the pump is not doing well. That's why we monitor those signs, the indicators, which can tell us that, hey, something is not right. Agree with me on that? Okay. So once again, how do they help bringing the blood pressure down? Because heart has a job to perform. Pump. What it pumps? The volume, fluid. And when it's more volume, it has to pump more, work hard, increase the tension, the pressure, hypertension. So by making more fluid going out from the body, you're giving less work to the heart to drop the blood pressure. Okay. These are different type of your diuretics, and these thiazide type, ending with mostly this, thiazide, hydrochlorothiazide is one of the most common one you will see. And then loop diuretics, your furosemide, Lasix is the most common one. This mannitol is used also to reduce intracranial pressure patients with certain type of brain surgeries or head injuries at that time to reduce that. You will see this. Spironolactone is the most common from your potassium sparing diuretic. And if you use that, you need to monitor patients' potassium because it's a potassium sparing diuretic. It spares, it let the potassium sit in the body. Okay. Kimberly, question?
Yes, whenever people are sick, like say they have the flu or something like that, and they're already going to be dehydrated, do you hold the diuretic? Because it seems like if they're dry for like an illness, like that it might overdo it.
No, not necessarily. You tell them to increase the fluid intake to keep them hydrated rather than putting at a risk of something to do with the pump. That is a bigger problem.
Okay.
Excuse me. This is another way to look at which one works where, your carbonic anhydrase at the proximal tubule, then your thiazide type diuretic, so they work at distal convoluted tubule, then your potassium sparing over here in the collecting duct, and the potassium sparing right here, a mnemonic seat means spironolactone, Clarinon, amiloride, trunk drain. It just, you don't need to know exactly where is what, but it's good to know some most common ones. Okay. Now, here are your vasodilators. They cause vasodilation. So treat hypertension by directly relaxing the smooth muscle in the blood vessel walls. So causing vasodilation, reducing the blood pressure. They are not the first line, usually given with other medication, and your hydralazine. Minoxidil is very commonly used. It comes in foam for hair growth, not for me, okay? It doesn't work for me. But minor loss, okay? It can help because, once again, causes vasodilation, oxygenated, rich supply of blood, that helps hair growth. Okay. Okay. Now, just a quick thing. Sodium nitroprusside, diazoxide, IV formula. They are for emergencies, hypertensive emergencies. Okay. I'm not worried much about it. No. Sorry, I don't want to play this. Okay. Nursing implication. So this is simply what we talked about in different categories, different classes, different medication. It's just a repetition, okay? Repetition. Before beginning any therapy, a thorough, as much as detailed possible patient history, okay? Assessment is the fundamentals. Ask them everything. Look for any contraindication which can put your patient at high risk. Any drug they take, any herbal supplement, ODC, any specific type of food habits, dietary habits they have. Then do they smoke? Do they drink? How often do they exercise? And very important, these drugs act on the pump, the heart, one of the most vital organs in the body. Make sure the patient do not skip the dose. Even more important, tell them never ever abruptly stop these medications. Never ever. That is a very important thing. Anything they want to stop, well, they need to talk to doctor. Anything they want to add, they need to talk to the doctor first, because it can increase the risk. Okay, Alexis, question?
Are you talking about vasodilators still? Because we skipped ahead the nursing implications of vasodilators.
All drugs, all antihypertensives. Okay. So if they miss a dose, they should ask first if they can take it. Based on the timeline, they can either take it or they may need to skip it, but tell them do not double dose it. Okay. And then this is once again, remember the important part again, never abruptly stop, because the problem is what? Wherever we started, what we started with, high blood pressure, right? So what did we use? The medication to bring the blood pressure down. Now, the drug which helps bringing the blood pressure down, if the patient doesn't take it, the problem rises again. Blood pressure goes high. So rebound hypertension, that is the problem. They will experience even, it could be even severe than where they started. Okay. All right. Also, educate them to read the labels, especially these packaged foods. Pretty much all of them, they have sugar and salt. I mean, extreme amounts. So make sure they read the labels and then educate them about making changes, reduction of stress level, performing yoga, exercise, whatever calms them down, healthy weight management, and then smoking, alcohol, cessation, those are important parts. And the bottom, it says encourage supervised exercise. What that means is that it's not that they just decide like, okay, I'm going to work hard, I'm going to lose weight. Well, it has to be supervised, means developed by somebody who knows how much they can handle and what they can do without putting them at any risk. For example, somebody taking antihypertensive. Now they decide that on one of the hottest days out, like, oh, you know what? I'm going to go out today. Okay, it's gonna help me sweat and all that. Oh, well, then to sweat, you're losing fluids. You're losing fluids, you're losing electrolytes. While your blood pressure might drop, electrolyte imbalance, and they might find themselves on the floor. Right? So we can't do that. Just supervise, like, has to be developed what is safe for them. And because these drugs can drop the blood pressure, safety precautions. Sit before you stand. Change position slowly. Do not take it with anything else, such as opioids, benzodiazepine, which can drop your blood pressure more. And monitoring any signs and symptoms of a problem with the heart pump, right? Edema means pump is not working. They're having shortness of breath. The lungs has abnormal adventitious sound. What that means, maybe the left-sided heart failure, right? When the patient has left-sided heart failure, the fluid backs up in the lungs, makes them hard to breathe. Weight gain. All these are indicators of issues with the pump. Also, educate them about the risk associated with taking too hot showers. Anybody ever felt like when you take too hot shower, like you're feeling a little dizzy, lightheaded? Yeah. The reason is it causes vasodilation, and vasodilation drops the blood pressure. To monitor two things, good and bad. Monitor therapeutic effects, monitor adverse effects. Okay, any question from this chapter? Any question, guys?
No.
No? All right, so let's do a few quick questions and then we'll take a break, okay? Okay, let's see. And you guys can type your answer in the chat. Okay, good job. Yes, excellent. Dry non-productive cough with ACE inhibitors is important to know. Okay, let's see if you can identify that. That should be an easy peasy one. There you go. Absolutely correct. Okay, nice. Beta blockers, right? Because the drug's ending with LOL. Those are beta blockers. Okay. Okay. Good job. Yes, C is the correct choice because calcium channel blocker will decrease the blood pressure, and you should certainly question if somebody's having a low blood pressure, why would we give it, right? Okay.
Sorry, Professor, I have a question for the last question. You said it was C. And in my notes, I had put that it was a dual acting. That's why I chose A. But you said it was just a beta blocker. Can you explain that a little bit better?
Yeah, no, remember, even though it's dual acting, but it's still under that umbrella term.
Okay, so it wasn't A, it was C.
Yeah, the previous one, right?
Um,
Which one are you talking about? This
one. Yeah. So it's
no. Okay, that was the dual acting. You know what? You're right. Okay, so
I think
maybe that
it's
was
A. I don't think it's C.
Sorry.
Sorry.
You are actually, it is a little confusing one. Okay, so leave that out. It's a little confusing. I know that how it can cause confusion. Thank you for pointing out. Leave
I
that
just want to
out.
make sure that for that one, okay, so that wouldn't be on the test because that's what I would have chosen. I would
Yeah.
have chosen A.
No, I won't put that on. Okay.
Oh, that's right,
Okay.
because
I know it
under
can confuse you.
Terran's right, because for labetalol, carvedilol, I thought they were the dual acting,
Correct.
because they
Correct.
go together,
So
labetalol, carvedilol.
it technically it could belong to both. They do how the question is posed. So I'll keep that away.
Okay, thanks.
So this one, D. All right, diuretics and calcium channel blockers. Okay, perfecto. Okay, so we are done with this chapter. So let's take a break. It is about 10:30, so let's take a 15-minute. So, but I would say 10:45. Okay. See you in 15 minutes. Okay, welcome back, everyone. Let's turn on the cameras and move on to our second chapter of the day. Excuse me. Okay, any question before we move on? Okay. And one thing I forgot to mention, I do receive your messages. Thank you for that regarding the remediation. So what I will do is I'll meet with whoever has remediations too, after the lecture. And we'll go over certain basic things, and then I'll schedule individual meetings based on availability and whoever needs to. But excuse me, I'll go over the basic things so you can at least start on. Kayla, you have a question?
Oh yeah, sorry, a little bit off topic, but for studying wise, for like our terms and stuff, are you able to unlock those practice assessment things that are there for pharmacology?
No, those are as a different, I think at a step, not here. That's later
Okay.
during the course or in the program. And
Got
that's
it.
where you get them, yeah.
Thank you.
Okay, let's move on, guys. Anti-anginal drugs. Anybody knows what is angina?
Chest pain.
Okay, and if we move a little bit more forward, I mean, why does it happen?
Not
Reduce blood
enough
flow to the heart.
blood to the heart.
Okay, good job. Okay, well, you guys already know it, right? Angina. What is angina pectoris? That is a chest pain or discomfort which occurs when the heart muscle doesn't get enough oxygenated blood, right? Now, there are many reasons. It could be an underlying condition such as a coronary artery disease or something else. The reason is, one way or another, the cause is a reduced blood flow through the narrow coronary arteries. So it's about demand and supply. So if you need 100, somebody's giving you 50, means the 50 is short, so the supply is short. Or maybe you're working hard rather than 100, you need 125, and you still get 100, you're short again. So either the supply is short or the demand is increased, right? That is why the first step, anytime somebody has angina, tell them to stop doing whatever they're doing. Why? You are trying to reduce the demand, correct? And you're working, well, you're going to spend more, right? You're driving the car, you're going to burn the fuel. So if you don't have the fuel, what you going to do? Well, until you can fill it, well, stop driving, right? It's not going to burn more. That's exactly what we do here. And majority of the issues here are, I'm going to go over those stable, unstable angina. And when you know that something is triggering it, the first thing to do is stop the trigger. Whatever they're doing, stop, sit down, relax, right? Okay, so as we just said, this is a condition because of imbalance between supply of oxygenated blood, right? Oxygen-rich supply. That's when heart aches. It tells you that I am not getting the full supply, guys, right? So here are a few terms here which I want you to know. First of all, ischemia. Ischemia means a reduced blood flow to tissues causing a lack of oxygen and nutrient supply. Okay, why does it happen? Usually because of narrowing or blockage of arteries. Example, atherosclerosis, right? Symptom, once again, that the chest pain, discomfort, depending on the affected organ, right? If it's associated with the heart, then heart ischemia, right? That's called ischemic heart disease. When the poor blood supply, it is associated with the heart, it's called ischemic heart disease. Angina pectoris, correct? When it happens with physical exertion, stress, now with your myocardial infarction, that simply means a heart attack. When a part of the heart muscle dies due to prolonged ischemia, means a prolonged period when it did not get oxygenated supply of blood. Okay, everybody is clear about the three terms mentioned here? Okay, next slide, very important. Focus on that. Especially stable and unstable angina. They are the topmost one. It's crucial to know the difference between both. What is stable angina? What is unstable angina? Now, think basic. When we talk something stable, when we talk something unstable, which one do you think is kind of maybe a little more riskier or unpredictable?
Unstable.
Unstable, right? So if we talk about stable, stable means it's also called classic. It is triggered by something, maybe an activity, exertion, and because it's stable, and whenever you address the cause, for example, it's because of some sort of activity. As soon as you stop the activity, problem resolve. Or when you give usual treatment such as nitroglycerin, problem resolve. That is called stable. Understood? Any question on that? Please let me know if anybody is not clear what is stable angina. Just remember simple thing. It has a known cause, predictable, such as exertion, emotional stress, something. So it resolves with rest or means stopping whatever the activity causing, or resolves with usual treatment, such as nitroglycerin and stuff. On the other hand, unstable. Now, instead of predictable, this is unpredictable. So all of a sudden, comparing the second thing, they're relieved by rest or nitroglycerin. This one doesn't. This usually happens even at rest or with minimal exertion. It is a medical emergency. Might be indicating a heart attack. Okay, everybody is clear about the difference between stable and unstable. Okay. Then your variant Prince battle or the vasospastic, this is another one caused by spasm in the coronary arteries, leading to temporary narrowing and decreased blood flow. This also occurs at rest, often during the night or early mornings. Okay, but the most important, you have to remember, there's stable and unstable, most common ones. Symptoms, once again, well, the chest pain, discomfort, so it feels like pressure, squeezing, tightness, and usually behind the sternum. It can radiate, the pain can radiate to the shoulder, arm, neck, or jaw, or to the back. And because of that, patient may experience like shortness of breath, fatigue, dizziness, or sweaty. And the reasons? Well, most common atherosclerosis, which is narrowing of the coronary arteries because of the plaque buildup. Okay. Let me see if I have a short video. That's
Angina comes from the Latin angere, which means to strangle, and pectoris comes from pectus, meaning chest. So angina pectoris loosely translates to strangling of the chest, which actually makes a lot of sense because angina pectoris is caused by reduced blood flow, which causes ischemia to the heart muscle, or lack of oxygen to the heart. Almost like the heart's being strangled, which causes terrible chest pain. Stable angina or chronic angina is the most common type of angina, and it usually happens when the patient has greater than or equal to 70% stenosis, meaning 70% of the artery is blocked by plaque buildup. This small opening that blood flows through might be enough to supply the heart during rest, but if the body demands more blood and oxygen, like during exercise or stressful situations, the heart has to work harder and therefore needs more blood and oxygen itself. It's during these times of exertion or emotional stress that people with stable angina have chest pain, since the blood flow isn't meeting the metabolic demands of the heart muscle, or myocardium. But the pain usually goes away with rest. In the majority of cases, the underlying cause of stable angina is atherosclerosis of one or more of the coronary arteries, the arteries supplying blood to the heart muscles. Other heart conditions that might lead to stable angina are ones that cause a thickened heart muscle wall, which would require more oxygen. This increase in muscle size can be due to hypertrophic cardiomyopathy from a genetic cause, or as a result from the heart having to pump against higher pressures, as is the case in aortic stenosis, which is a narrowing of the aortic valve, or hypertension. These larger, thicker heart muscles require more oxygen, and if the patients can't meet the increasing demands, they feel pain in the form of angina. Whatever the case, the heart needs blood, and if we look at the heart wall, there's 3 layers: the outermost layer, the epicardium, then the myocardium in the middle, and then the endocardium inside the heart. The coronary arteries start up in the epicardium, and then dive down and supply all the heart tissue. If blood flow is reduced or the myocardium is thicker, blood has a harder time reaching the deeper layer just under the endocardium, called the subendocardium. Therefore, the classic finding with angina is subendocardial ischemia, meaning less oxygen is reaching the region just under the endocardium. This ischemia is thought to trigger the release of adenosine, bradykinin, and other molecules that stimulate nerve fibers in the myocardium that result in the sensation of pain. That chest pain is usually described as feeling like pressure or squeezing, and it can radiate to the left arm, jaw, shoulder, and back, and sometimes is accompanied by shortness of breath and diaphoresis or sweating. Usually the pain and symptoms last less than 20 minutes and subside after the exertion or stress is taken away, and therefore the heart muscle isn't demanding as much blood. Now, unlike stable angina, which describes when patients have pain only during periods of exertion or stress, but not during rest, there's also unstable angina, which is when patients have pain during exercise or stress as well as during rest. It never really goes away. Unstable angina is usually caused by rupture of atherosclerotic plaque with thrombosis, meaning a blood clot forms on top of a mound of plaque. Although the occlusion might not block the entire vessel, there's now even less room for blood to flow by, and the heart tissue is starting to feel starved for oxygen even while pumping at a normal rate. Unstable angina, for the same reason as stable angina, involves subendocardial ischemia, and it should be treated as an emergency because patients are at a high risk of progressing to myocardial infarction or heart attack. The key distinction is that unstable angina means that the heart tissue is alive, but ischemic or starving for oxygen, whereas myocardial infarction means that the areas of the heart tissue have already begun to necrose or die. Now, a third type of angina is vasospastic angina, also known as Prinzmetal angina. and patients may or may not also have atherosclerosis. Ischemia and resulting chest pain is due to coronary artery vasospasms, meaning the smooth muscles around the arteries constrict extremely tightly and reduce blood flow enough to cause ischemia. Episodes of vasospastic angina don't correlate with exertion and can happen anytime, including at rest. The underlying mechanism causing vasospasms isn't well understood, but likely involves vasoconstrictors like platelet thromboxane A2. Unlike both stable and unstable angina, in this case the coronary arteries constricted so severely that all layers of the heart wall being supplied are affected. Therefore, it's referred to as transmural ischemia. All right, so if we line these three up side to side, there's some important clinical similarities.
Okay, any question about this condition so far? Does everybody understand the basic concept? Yes? Any
Yes.
confusion? Okay, all right, thank you. Now, in order to manage this, first, you start with the least, means lifestyle modification, smoking cessation, and healthy diet, such as saturated fats, decreasing cholesterol, so decreasing sodium, regular physical activity, weight management, stress reduction techniques. Those are non-pharmacological management techniques. Now, if that doesn't help or additional help needed, that's where the medication comes. Your nitrates or nitrites, such as your nitroglycerin. And nitroglycerin is used to relieve acute symptoms. Okay. And how? Causing vasodilation. Remember what is short? Supply short of oxygenated blood, right? And you cause dilation, increasing the supply. And as soon as they receive the supply, well, it stops aching. Then beta blockers. They reduce the heart rate and they also decrease the myocardial oxygen demand, causing less stress on the heart. Less demand means they have to work less. Calcium channel blockers. Okay, they also decrease the demand of oxygen. And then along with that, based on the underlying conditions, your patient may need like antiplatelet agents, statins if their cholesterol is high, but primarily for that purpose only, these are most commonly used drugs so that we can increase the supply and reduce the demand. Okay. Oops. All right. So nitrates and nitrites. So just remember that the most common, your nitroglycerin. So comes in various forms, such as sublingual, IV, transdermal patches, ointment, translingual sprays, and your sublingual, IV, translingual. Those forms works quick. Okay, oral cannot be given for any acute relief, right? Do you guys know what is the criteria for using your nitroglycerin? How to use it? What steps? Anybody knows?
No.
Okay, that's okay. All right, so let's know it. All right. After 1 minute, you all know it. As soon as the patient feels that angina, okay, take the first dose. Take the first dose. Now what to do? Anybody knows after that? Wait for 5 minutes. Now, two things can happen. Either the patient will feel better or not. If they feel better, good. If they don't, take second dose. Okay. Now, once again, what to do? Wait for 5 minutes. Two options. Either the patient will feel better or not. If they do, perfect. If they don't, take the third dose. So now how many doses in total? 3. Correct. So that's the maximum they can take. What is the duration in between each dose?
5 minutes.
5 minutes. So everybody knows the maximum dose, doses they can take, 3, and the interval between each dose is 5 minutes. We all clear? Now, another thing, let me go back and add. The patient took the first one and then they waited 5 minutes before they took the second dose, right? After 5 minutes. What I want you to remember here. The patient took the first dose, waited 5 minutes, but the patient still experiencing the pain before taking the second dose. There's one step. There's another thing to do. Call 911 first, then take the second dose. Then wait for 5 minutes, take the third dose, and wait for emergency crew to reach. All right. Do not drive because hypertension. Okay. And make sure the difference between calling 911 before taking the drug or taking the drug, the second dose, and then calling. Always call before taking the second dose. What if they experience a myocardial infarction, heart attack, and they're not even able to take the second dose after that while they are calling? So that's a high risk, correct? Ask for help when you can, right? And take the dose. Everybody's clear about the steps? Everybody knows? Is there anybody still have the same answer? No?
I'm clear. I just have a question. So after the first dose, if the pain improves, should they still go to the doctor or?
Yeah, so I would recommend if they have angina, it's always good to get them checked because you don't know which side they're heading to, left or right. You don't know if that is what their experience is gonna be stationary or is it temporarily while the drug is acting and they fall back again. Make sense? We have to assume the worst, right? Okay, anyone else? Any other question? Excuse me. Everybody knows it? Yes? Okay, okay, okay. That's what we wanna do. It's okay if you don't know, but we should know before we go, right? I'm not gonna play this either. Okay, now let's talk about some important things for your nitrites. Very commonly used this nitrostat, your nitroglycerin, which is your 0.4 milligram or 400 microgram in the different units, right? These are for rapid or acute use. Okay, these are not. These are for management, long-term management. Orals. This is also for acute, nitrolingual. It's a spray. Just a different dosage form, but acts same way. Now, we know about this we talked about, or this, same concept applies. Now, what if it's a ointment form or if it's a patch? A few more things to add. Either it's a patch or an ointment. The old application should be removed before applying the new one on a non-hairy and where there are no open cuts on the skin or wounds, non-hairy parts, non-irritated skin. Tell them not to apply with the bare hand, with the gloves, or use a tongue depressor to spread it. They don't have to massage it there, you just spread it. Okay? Then tell them, do not cover the area with a plastic or something thinking, okay, I'm going to cover it, keep it safe. No, because that can change the absorption. Similarly, do not apply heat on it. The reason, heat is going to do what? Heat is going to increase the absorption, the risk of hypotension. It's meant to get absorbed at a rate, certain rate. But if we increase the rate, it's going to increase absorption and higher chance of adverse effect. And finally, rotate the site of application. Everybody clear? Any question? Okay, let's move on. So these are very important things, okay? How does it work? Once again, causing vasodilation. Vasodilation. Vasodilation supplies more oxygenated blood. And that's what the problem was. Okay. Now, rapid acting used for acute attacks, long acting, your orals, they are used to prevent any future attacks. What are the problems? What is the biggest concern here? With this medication? Hypotension, right? So we should take all precautions to prevent that, right? Somebody who has hypotension, we shouldn't be giving it to them, correct? We should not be giving along with others, which can cause severe hypertension. So very, very, very extremely important thing. Never, ever, and one more never, and one more ever, okay? And you can add as many as you want. Never, ever give these nitrates, nitrites with erectile dysfunction drugs such as Viagra, Cialis, which is sildenafil, vardenafil, tadalafil. Never ever give it to them. The reason? Most likely your patient will end up opening their eyes in the ER. Reason? What nitrates, nitrites do? Hypotension, correct? Vasodilation. What do these sildenafil, vardenafil, tadalafil do? They cause vasodilation, increase the blood supply. Now, two things causing severe hypotension. You'll be in la la land, right? We don't want that. Very high risk. Everybody clear. This is a huge no-no. Okay? Very important. Okay. Never miss this thing. Kimberly, question, ma'am?
Are there indications for the ED drugs for heart use for the vasodilation? Do they use it for the off-label use like that, like a daily?
No.
No. Okay.
There's some doctors you may see trying things, okay, but it's not common practice. Okay. Now, a couple of other things I'll add. Remember what I told you, the biggest concern, the biggest risk is what?
Hypertension.
Hypotension. Now, one more thing, and understand the difference. Two things. One is the most severe risk, the second is most common risk. Correct? Two different. Most severe is hypotension, most common is headache. Okay? Who's flying those balloons?
It's an effect with Apple.
Okay. Oh my goodness. I thought it's you guys are doing that. That's okay. Look at bright smile on your face, right? That's okay. All right, guys. So two things. Most common, most severe. Most common is headache with this drug. Most severe is hypotension. Everybody understand those two and what the difference is. So please don't get confused. Don't mix up with most common and most severe. Okay. Now, third, tolerance means this drug is known. With long-term use, the patient may not respond the same way how they used to. That's not addiction, okay? It's tolerance. The body doesn't respond the same way. Then what is the solution to avoid this? Well, they call as nitrate-free period. Means you should not apply it continuously for 24 hours. You should take it off for 10 to 12 hours at least. And the ideal time is at night. Why? Remember, why somebody is having angina? Because either the supply is short or the demand is more, right? So when somebody is doing something, the demand is more. Well, when somebody is laying down, that's the demand is the shortest, right? The smallest demand they can have when they're not working hard. So we take it off at night so that they don't experience that shortage, and we apply it back in the morning. That can avoid this tolerance issue. Everybody understood? Any question, guys? All right, so we'll move on. Now, this is the same thing. It applies the same way, either it's a patch or whatever it is. And these are your long-term management, okay? This is your nitroglycerin, the most common. We talked about everything important about it. Now, all oral drugs, okay? Remember, sublingual and all, that's a different dosage form. That doesn't fall in that long-term oral thing. Those are your capsule tablets. And we don't use them for acute attacks because they have to go through the first pass effect of liver. And it takes more time as well, and majority of the drug gets excreted from the body without producing effect. Now here's the next drug, beta blocker. Beta blockers ending with LOL. So they're used for hypertension as well as for angina. Okay? They end with LOL. Nothing changes, guys. Nothing changes. So they decrease the heart rate, they decrease the oxygen demand, increase the supply. Okay? And once again, these drugs we need to be careful patients with asthma, COPD, as well as diabetic patient because it can mask the symptoms of hypoglycemia. Right? Okay, now, whenever you use these drugs, antihypertensive, no matter the beta blockers, there are others, and for whichever the indication you're using, make sure you're not giving it to the patient if their pulse rate is low, right? And the number is 60. Either for this purpose or you're giving for hypertension. If the pulse rate is below 60, a super nurse will hold the dose and call the doctor. Hold the dose, call the doctor. Okay. And once again, asthma, COPD patients, we're going to be careful about. And diabetic patient, because of the risk of hypoglycemia. But can we give it? Yeah. All we got to do is we got to monitor it frequently so that blood glucose doesn't drop unexpectedly. Okay. So nothing different here. Nothing. This is all what we already talked about. So if you're giving them the beta blockers, remember that below 60, we have to hold the dose, call the doctor. So the risk here is bradycardia, the slow heart rate. So you're going to monitor your patient for bradycardia. That is important. Okay. I'm not worried about this much because these are more impotences because of long-term use. Now, these are some examples. Nothing different, same drugs. It's just an added indication. Now, calcium channel blocker, they're the same, ending with pine. Dihydropyridine, non-dihydropyridine, which has verapamil, diltiazem, same thing. It's just another condition or indication they are used for. Their characteristics are never going to change. Same thing, causing vasodilation, decreasing the workload on the heart. Nothing different. Okay. Okay. Let's talk about a few points. Okay. Calcium channel blocker starts with C, and they can cause constipation starting with C. Okay, so that is something also important. Educate your patient to consume more fiber and fluids. And if it becomes chronic, make sure you educate them to use fiber and fluids rather than using stimulant laxative for a long time, because stimulant laxative used for more than 3 to 5 days can cause bowel dependence, means the bowel may lose its natural tone and the patient may not be able to go to the bathroom without using. Okay. And another important thing, they should not take calcium channel blockers with grapefruit juice, because grapefruit juice will decrease the efficacy of calcium channel blockers. And the common rule, do not abruptly stop. Another basic fundamental rule, any dosage form which is extended release, sustained release, controlled release, should not be chewed or crushed. Okay. All right. Is your diltiazem, nothing specifically you have to focus on. Same here with the amlodipine. I just like to put some pictures so that it kind of, gives you an idea. When you see that drug, you will recognize it. Now, nursing implication, reputation, what we talked earlier, guys. Make sure you monitor any issues associated with the problem here with the heart, which is your pump. So when they have issues, means they have issues with the pumping. And when they have issues with the pumping, the fluid probably backing up. When it's backing up, where it is going? Well, it's staying in the body. So it will show somewhere, right? Edema, weight gain. Somebody is having trouble breathing. Those are all indications that probably the pump is not working effectively. So they have a weight gain of more than 2 pounds a day or 5 pounds or more in a week. That is the problem. They're having shortness of breath. While maybe they're drowning in their own fluids. Left side, heart failure. And because these drugs drop the blood pressure because of vasodilation, make sure the fall risk. Educational points: change position slowly, sit before you stand. Don't take anything else which can make your symptoms worse, such as benzodiazepine, opioids, alcohol, all those things applies. And once again, important drug nitroglycerin, educate them how to use it correctly, right? And you may see this in some, they may say 3 months, and some they say 6 months. Different manufacturers may have different recommendation, but based on manufacturer recommendation, the bottle should be replaced, even though it was sealed. But if the number of months written on the bottle it's good for, even though it's never opened, it should be discarded, new one should be used. And if you see the bottle here, it's dark color because direct sunlight can degrade the drug, so they should always be protected from direct sunlight or heat. So people and people do this. Oh, you know what? I keep an extra bottle in my car glove box, right? Now, from their point of view, they're playing it smart. Like, who knows where they might need it? They have it home. What if they were driving the car then? Well, that's not the smartest thing, because in this hot weather, if you're putting in the car, maybe the drug is it's not even good anymore. It's degraded now. So I know it's extra work. Put in your pocket. Don't leave in the car. So it's important that we do it in the right manner. Not just having it is not gonna solve the issue. Okay, and we talked about the topical, what to do: patch, ointment, remove the previous application, rotate the side, non-hairy, non-irritating, with no cuts or anything on the skin. You apply it, rotate it, and whenever you are cleaning the application, you don't need to rub hard. It's just washing with just simple soap and water, and then just tap dry and apply with the tongue pressure, or uh, putting gloves on and just kind of thin application. Do not use with bare hand. Okay, remember, topical product, it will be absorbed through skin, right? So it can cause hypotension. All right, so going back to where the problem started, angina. Stable because of exertion activity. First thing to suggest to your patient, stop what is causing the problem. If it's activity, stop the activity. Sit down, lay down. And then nitroglycerin, we are clear about total 3 doses, interval in 5 minutes. And before taking the second dose, if they're still experiencing pain, call 911. Maximum dose is 3. Correct? Now, a couple of things which are equally important. We talked about sublingual, oral, but if it's an IV, now IV nitroglycerin should be in a non-PVC bag, and a non-PVC tube should be used, because it can cause absorption and uptake of nitrate by the IV tubing, and the bag can cause decomposition, a degradation of the drug. Okay, so never in a PVC bag, never use a PVC tube. It will degrade the drug. Always non-PVC bag and tube, and always protect it from direct sunlight. Everybody's good? All clear? Any question? Any question? Anything at all which didn't make sense to you, or anything which is not completely clear in your mind? Yes, Kimberly, go ahead.
So it says to discard the solution that is blue, green, or dark red. What is that about?
That is 100% correct. If you ever see nitroglycerin, which is blue, green, dark red, that is bad. Toss it.
So it's spoiled or something or interacted?
Yeah, it's degraded, either direct sunlight or it's not in the correct bag, as I said, maybe it's in the PVC bag, or direct sunlight is something which can cause that degradation of the drug.
Okay.
Good question. Very good. Anybody else, guys? Anything else you're doubtful about? Please don't hesitate to ask. I do not expect everybody to catch everything. As I say, it's okay to ask. If you didn't catch it the first time, it's okay to ask again. Okay, everybody's good? I want to make sure we walk together. I don't want to run, okay? We'll walk together rather than running around, right? I know it's a lot of information, a lot of new information, and a lot of complex information. Every week we move forward, it's lots of new complex information. So just keep your pace up with new information as well as the amount of information. The previous week, it was much less. So this week more, next week a little more. So just keep your pace up. Okay. We cannot, yeah, we can definitely breathe in between. We can have short breaks. We can't have long breaks. And pharmacology doesn't like long breaks. If we think that, oh, you know what, I'm going to take care of the other subject for 2 days, then I'll come back and touch pharmacology. So pharmacology is not going to like that. Okay. So always say hello to pharmacology every day. You know, you can say it's a little egoistic, right? It's just not just bad behavior, but we have to keep up with it, right? So just more or less every day include some activities. Stay connected. Okay. All right. So let's see. We're gonna do a couple questions and then we will take a break. Okay, what do you guys think? And good job. All right. So A is the correct answer. And why is that correct, guys?
Up to 3
You can all
tablets.
take it 3 tablets within 15
There
minutes.
you go. Perfect. Okay. All right. Excuse me. Okay, come on, come on, come on, guys. All right, looks like everybody got a D. These are common. These are common things. You know, as long as it's minimal, it's not really severe, that's okay. Okay. Next. Okay. So fine little confusion here, okay? Make sure we don't mix things. I know that maybe all options are correct, but not for this question, maybe belong to something else. So I see here a few students selecting A because we talked about grapefruit juice, but it belongs to which drug?
Grapefruit with your cholesterol
Calcium
mix
blockers.
and calcium.
Calcium channel blockers. That's what we talked about in this chapter. And it applies to statins as well, but calcium channel blockers. So grapefruit juice, even though it's correct, but not for this drug, it was there, a different drug. So here, potassium sparing diuretics was with which one? Spironolactone, correct? That's where we need to monitor because that's a potassium sparing diuretic. ED drugs, and why is that important?
Causes vasodilation, and vasodilation with both can cause.
Yeah, vasodilation, both have hypotensive effect. And that is a big red flag right there. Okay. So is everybody clear now why we selected D, not A? Okay. Okay. So now here I see a little confusion here. Now think you as a nurse standing right next to that patient, ready to give that medication. What is the priority? Okay, let's talk about the points. A says obtain a blood pressure reading. Let's see, discuss, is that relevant or not? If yes, why? Isosorbide mononitrate. Now, what is that?
The long acting, primarily
A
long acting.
vasodilator, right? It's a vasodilator. So vasodilator is going to do what?
Lower your blood pressure.
Lower blood pressure.
Lower the blood pressure. So is it important before giving the medication to check the blood pressure?
Yes.
Then only you can determine is it safe to give it or not, correct? Assessment is the first thing. Anything may or may not happen. Depends if you're going to give or not, if you can or you can't. Make sense? Nothing can happen if it's not given, correct? No adverse effect until taken. So first thing is, can you even give it? You assess the patient, the criteria, which is safety, and safety here specifically about the blood pressure, because that's what it's going to drop. Now going to B, advise the patient Tylenol is used to treat headache. Yeah, absolutely fine. No interaction. Now, majority of you selected C, emphasize that the patient should swallow the tablet whole. Now, if you go back to the question, sustained leads, we talked about it, that shouldn't be done, right? Or modified dosage form should not be chewed, swallowed, yeah. But does it even matter if you're not even going to give it? It only matters if you're going to give it. But the first thing is, can you give it? And can you give it depends on what is their blood pressure. Does that make sense? Are you on the same page? We agree on it? So think practically, put yourself right there, right next to the patient. Assume you are standing right there. What is important now? Think that way. Because remember, here maybe a couple of the option didn't belong, but they may give you all correct options, but the first thing, the priority, these key terms can make a complete change what answer you should be searching for. Okay. Right. For anybody who still do not have that clarity that why we are looking to that option rather than others. Because I want you to understand that point. That is important. How to look at the answer options, because they may give you all options correct, apply to the same concept, but based on what they're asking you changes everything. Okay. All right. So you guys ready for a break? Before this upset lady makes it hard for us. All right. So let's take a break, guys. It's 11:42. So let's take a 15-minute. Okay. All righty. See you shortly. Yeah, welcome back, everyone. I believe it's about time. Okay, let's turn on the cameras, please. Okay, let's wrap up the last chapter. Heart failure drugs. So we're going to talk about different drugs used for different heart issues, including the heart failure, contraindication, indication, interaction, all that kind of stuff, and important aspects of a nursing care plan. Let's understanding the basic concept first. Heart failure means pump is failing. Okay, heart is unable to pump sufficient blood to meet the body's needs. Right? So it can be your systolic or diastolic. Systolic heart failure is when the ventricles can't pump hard enough to meet the supply. It's not about filling up. Ventricles are filled up but can't pump hard. On the other hand, diastolic, it's not filling up enough. Okay, your ventricles, one cannot pump, the other one cannot fill. Two different issues. Okay. So there are many reasons which can cause this heart failure. Then symptoms usually, once again, related to what side of the failure is. Is it left side, right-sided, and the symptoms are associated with that. Now let me give you a little tip to remember. Left-sided. Left starts with L. The symptoms will be associated with another L, LL. Left-sided, symptoms in lungs, respiratory symptoms. Hard time breathing, shortness of breath. When you listen to their lungs, you will hear those sounds, the crackles and all that, because the fluid backing up in the lungs. Now, if the fluid is backing up other parts of the body, that's a right-sided heart failure, such as edema, like in extremities, right? So that is a right-sided. Okay. Once again, left side failure, fluid in the lungs, that's where you will see the symptoms. Right-sided in the body. Okay. I'm not gonna play the next video because we will be late if we do so. Now, different reasons why it happens. As I said, many that could be, myocardial infarction, heart attack, coronary artery disease, AFib, and all ischemia, any severe infection that can cause as well. There are many, many conditions which can put you at risk of heart failure. Now, American College of Cardiology classified different stages of heart failure as class A, B, C, D. So A means the patient is at risk, but no structural heart disease or symptoms of heart failure yet. Okay, for example, patient has hypertension, they have diabetes, they have coronary artery disease, family history of heart disease, but they do not have symptoms, either structural abnormalities either. So they are just at risk. Understood? Stage B is where structurally there is abnormality can be observed, structural heart disease. In the image you can see but they still don't have any symptoms yet. For example, prior myocardial infarction or left ventricular hypertrophy. So structurally, something is abnormal, but they don't have symptoms yet. They don't have symptoms right now. That's stage B. Okay. Then C, that heart failure with symptoms. Structurally, you see something not normal, but they also have the symptoms such as shortness of breath. They are tired easily. They cannot do exercise well. All are indicators or symptoms of heart failure, and they have a structural abnormality as well. Okay. Then D. D is called refractory heart failure. This is advanced heart disease with severe symptoms. Even with the treatment, means they are having symptoms even at rest, frequent hospitalization, or developed end-stage disease. That is your refractory or the stage D stage of heart failure. Okay, next slide. Extremely important, guys. Please understand this well. 3 terms here, 3 things on it. They are all positive. Negatives are going to be completely opposite to them, but let's understand positive. Positive, positive, positive. Now, 3 different terms. Positive ionotropic drugs, positive chronotropic drugs, positive bromotropic drugs. So for that, we need to know what are the inotropes, chronotrop, dromotrop. Let's do that. Number 1. And correlate it to your heart failure issues. That's when you can understand how they're going to help your patient. Remember heart failure when heart cannot pump well, right? It cannot fill or pump well. That was the problem, correct? With the heart failure. So if it cannot fill well, technically, we need to let it fill well. And in the other scenario where it cannot pump well, means we need to make it strong enough that it can pump well, correct? That is the solution. And that's what exactly these drugs are going to do. Number 1, positive ionotrop. Okay, what are ionotrop? They increase the force of myocardial contraction. Remember, if they're not able to pump well, means they're not contracting strong. Okay, and not on regular basis. Okay, frequency as well as the strength is not there, right? So this gives the heart muscle strength to contract so that it can push the blood, increasing or meeting the supply to the body, correct? So positive ionotrop, important to know. How do they work? They increase the force of myocardial contraction, which increase the cardiac output, right? Who we give it to? Well, it's to improve the function of the pump, the heart. So whoever has that issue, heart failure, or somebody's in cardiogenic shock. What is the shock to heart? Means somebody is in shock, like you stop whatever you're doing, just in a shock, right? And same with the heart shock, heart supposed to pump, and in a shock, flatline, it's not pumping, right? So you need to contract the heart to start it functioning again, which its job is to contract. That's when it's used. Now, let's talk about some examples. Add some examples to each one of them. For example, dobutamine does what? Increase the contractility, eventually improving the cardiac output. Dopamine, milrinone, digoxin. These are all your positive inotropic drugs. Let's move to the number 2, positive chronotrop. Now, what is a chrono? A chrono means dial, right? A dial. What goes on a dial on a watch? Time, correct? What goes along with time as far as related to heart? The heart rate, correct? So this increase the heart rate. How does it impact? Well, the heart is not pumping well. And one of the reason might be heart rate is not good enough. It's low, not beating enough times to supply enough required blood. And when you increase the heart rate, it's beating more, contracting more, supplying more blood. All right. I agree. Yes, no, no, yes. Yeah. Think simple. Think simple about problem. Think simple about the solution. Okay. So increasing the heart rate, more times it's gonna beat, more supply. And that's what the problem we're experiencing, right? Okay. So that is your positive chronotrop. Third, positive dromotrop. Now, how does the heart beat? Who tells it to beat? The impulses coming from
SA node, or I don't know.
yeah, the SA and AV node, right? They send the impulses. And what does they do? They increase the conduction velocity of these electrical impulses through the heart. Okay, so that means once again increasing the cardiac output. All these things meant to increase the cardiac output because that's what the problem was. Heart is not pumping enough. So method, the way could be different, but the output is same. So example, sorry, I forgot to give you example of a positive chronotrop. So positive chronotrop like your atropine, epinephrine. Then your positive dromotrop, examples, phenytoin. Okay, so positive inotrop, increase contractility. Positive chronotrop, increase heart rate. Positive dromotrop, increase the conduction. Everybody clear? Understood? Any question? All good? Okay. Let me see how long is this.
Hello. In this
Actually, it's about 6 minutes, so I don't think it's a good idea because we do have quite a bit to cover. Okay. Now, as far as the solution as the medication, if we talk about the different classes of drugs can be used. As we talked about positive inotrop, chronotrop, dromotrop, as well as your ACE inhibitors, ARBs, diuretics, beta blockers. Okay, they can be used. Let's talk about them. And as for these ACE, ARB, beta blocker, diuretic, it's just another added indication the problem they are used for. All their characteristics are going to stay the same. Now, if we talk about positive inotrop once again, increase the strength of or force of myocardial contraction, resulting in increased cardiac output. Correct? Now, cardiac glycosides fall such as digoxin, very important drug, digoxin. The reason it's called cardiac glycoside, but this drug has a narrow therapeutic index, means it needs serum drug monitoring. It can become toxic quick. Okay. Then your dobutamine, milrinone, these are other drugs under this category. Okay. Then during the early treatment of heart failure, ACE inhibitors, you will see ACE or beta blockers. Then loop diuretics, they increase the outflow, decreasing the stress on the heart. Okay. Let's talk about some common drugs, important drugs. Now, dobutamine, isosorbide, hydralazine, they're all positive. The dobutamine, they're all positive inotropic drugs. Okay, positive inotrope. Then your hydralazine and isosorbide, they come individually as well as in combination as called bidyl. It's more specific, I would say that more appropriate for African American, much better response. Then ACE inhibitors, once again, gonna do the same thing. How it acts as a hypertensive agent, antihypertensive agent, ending in pril, pril, pril. These are some examples, and the adverse effects are going to stay the same, and the most unique one, the dry non-productive cough, and the patient may experience hyperkalemia, means too much potassium in those patients. And with ARB, once again, ending in sartan. And the important part was not to give in patients with who are pregnant or lactating. That's what important. Then beta blockers, once again, ending with LOL, correct? And which patient population we should be careful, or with conditions?
COPD and asthma patients.
There was one more thing.
Asthmatic patients.
Yeah, asthma, COPD, and one more.
Diabetic. There you go.
Yeah. Asthma, COPD, and diabetic patient. The reason is different, right? Asthma, COPD, it causes bronchoconstriction, airway constriction. In diabetic patient, it can mask the sign and symptoms of hypoglycemia, low blood glucose. Right? Okay. Aldosterone antagonist. So these are also used in heart failure patients to reduce the symptoms and also improve outcomes. How it works? By blocking the effects of aldosterone. Aldosterone is a hormone which promotes sodium and water retention. And when there's more sodium, more water, they go together, sodium, water. So sodium, water retained, more volume to pump, more stress on the heart. And that is a problem. So by blocking that, the aldosterone receptors, you are inhibiting the sodium and water retention, reducing the blood volume so that less stress on the heart. Example, spironolactone, your potassium sparing diuretic. And whenever your patient is on potassium sparing diuretic, most common you will see spironolactone, you should monitor patient's potassium because it's a potassium sparing diuretic. It lets water go out, but leave the potassium in the body, raising the potassium level. Okay. This is how it looks like your spironolactone. And monitoring potassium is very important. So does it cause hyperkalemia or hypokalemia? Hyperkalemia. That should be monitored. Now, Another drug, nasiretide, it falls under B-type natriuretic peptide, or BNPs. Okay. It's a hormone. It's a hormone produced by the heart in response to stretching of the heart.